Hello, everyone. My name is Jane Barrow. I'm the Executive Director of the HSDM Initiative to Integrate Oral Health and Medicine. And on behalf of the initiative and HSDM, it is my pleasure to welcome you to today's webinar, a discussion of some important and historic legislation. I'd like to introduce today's moderator, Dr. Sheenam Taku. Dr. Taku is an instructor in the Oral Health Policy and Epidemiology Department. She is also an investigator in the Center for the Integration of Primary Care and Oral Health, as well as with the initiative. Dr. Taku.
Thank you so much, Jane. It's an absolute honor to be here today, especially with such august company. Before I actually introduce this fantastic panel, I want to tell you about some housekeeping. Please use the Q&A function on your screens to ask your questions. I'm looking forward to a robust discussion in the chat section, but please, for questions, use the Q&A function, and we will address them towards the end of the webinar. This recording will also be posted to the HSDM Initiative website in the coming weeks. So today we have, like I said, a fantastic group of panelists and subject matter experts. To begin with, we have Dr. Pamela Alston. She's the president of the National Dental Association, dental director of the Eastman Wellness Center in Oakland. She's been providing dental services to the underserved and disadvantaged communities of Alameda County, California, and beyond since 1983. Her experience includes more than 10 years of providing dental care at Santa Rita and now North County jails, and more than 20 years at the Central Health Center in Oakland. We have with us Professor John McDonough of the Harvard T.H. Chan School of Public Health. Professor McDonough is Professor of Public Health Practice in the Department of Health Policy and Management. He also is the Director of Executive and Continuing Professional Education. He served as a senior advisor on national health reform to the U.S. Senate Committee on Health, Education, Labor, and Pensions. And he served as Executive Director of Healthcare for All, a Massachusetts leading consumer health advocacy organization, and also served as a member of the Massachusetts House of Representatives, where he co-chaired the Joint Committee on Healthcare. We are joined with Dr. Michael Monopoli, who serves as a Vice President for Grant Strategy for CareQuest Institute for Oral Health. Previously, he's held a number of senior roles within the DentaQuest Partnership and Delta Dental of Massachusetts, and served as a dental director at the Office of Oral Health for the Massachusetts Department of Public Health. He also serves on the boards of director of the Forsyth Institute and Cambridge Health Alliance Foundation. And last but not the least, we have Mary Otto. Mary Otto is a Washington, D.C. based independent journalist who began writing about oral health at the Washington Post, where she covered social issues. She spent an academic year studying oral health at the Harvard School of Dental Medicine as a Knight Science Journalism Fellow. She's also the author of the book Teeth, The Story of Beauty, Inequality, and the Struggle for Oral Health in America, published in 2017 by the New Press. Thank you so much to the panelists for joining us today. So in the United States, oral disease is highly prevalent among adults over 65. A lot of these stats are probably not news to most of the people who have joined us. 20% have untreated cavities and almost 70% have gum disease. We know dental health is intertwined with systemic health and quality of life. Mounting evidence shows robust connections with diabetes, cardiovascular disease, Alzheimer's disease, and aspirational pneumonia. Problems like tooth loss, ill-fitting dentures, and dental pain impede proper nutrition and lead to impaired speech, altered appearance, reduced self-esteem, and even limit functional capacity. All of these can worsen social isolation and loneliness, already public health risks among this population. And yet, dental benefits are not covered in Medicare, except some circumstances deemed medically necessary. As you can see on your screen, this disproportionately affects people of color. Nearly half of all Medicare beneficiaries and more than 2/3 of Black beneficiaries did not visit the dentist in the past year. And since COVID, these statistics have probably gotten worse, as a lot of older adults couldn't visit a dentist due to the pandemic. While some people on Medicare may get dental coverage through Medicare Advantage or other private plans, as you can see this beautiful graph from Kaiser Family Foundation, currently nearly half of people on Medicare have no dental coverage. So with this as our background, I really want to start with Dr. Monopoly and Mary Otto to give us some background around this exclusion of dental benefits from Medicare, this kind of historic separation, if you will.
Thank you. So great to be here. Can you hear me okay? Okay, great.
Yeah.
Well, as a journalist, I had a chance to explore the historic separation of our dental health care, our oral health care system from the rest of our larger healthcare system. And working in Washington and covering Maryland, I was surprised to find out that historic fracturing of our healthcare system occurred right in Baltimore. It was about, not such a far drive from the office where I worked. And it occurred in Maryland, in Baltimore, back in 1840. And this event is remembered in the annals of medical history and dental history as the historic rebuff. And as the story goes, been accepted for years. These two, in 1840, dentistry was considered more of a trade. It wasn't a profession yet. Medicine at that time was growing. There was a growing awareness of its professional status, and even specialization was starting to take root in many ways. But whoever considered himself and called himself a dentist was a dentist, a practicing dentist. And dentists learned their skills in an informal system, a preceptorship system that really dated itself back to the Middle Ages as sort of apprenticeships, but these two serious self-trained dentists, Horace Hayden and Chapin Harris, back in those days, had both thought very deeply about the practice of dentistry, and they were they were learned men as well as practicing dentists. And as the story goes, they approached the physicians at what has become the College of Medicine in Maryland, University of Maryland College of Medicine, and asked if they would consider adding a course of dental training to the medical curriculum. And as the story goes, the physicians told them that the subject of dentistry was of little consequence and sent them on their way. But these two determined men established what became known as the world's first college of dentistry. And Chapin Harris wrote the first textbook, and he drew upon knowledge that he had gleaned from text and writings he had imported from France and England, and they had their collection of anatomical specimens that they used, and they taught a lot of the first lectures in their own homes and in a nearby church. But this school took off and the model took off, and before long, cities and around the country had established dental colleges. Most of them were and remain technically very separate from the medical schools. Harvard is a rare exception of that, but the whole providers, we continue to be trained separately, and medical and dental providers continue to be trained separately. We find as patients our care largely in separate places, although that's starting to change. Our dental records and medical records have been historically kept separately and even have relied upon different kinds of coding languages. Researchers have to overcome institutional barriers to work together to understand these important connections that Dr. Tico just mentioned. And care has been financed separately, and that extends to these important federal programs like Medicare and Medicaid. The millions of people working and poor Americans who rely upon Medicaid. Children are entitled to benefits, dental benefits under Medicaid, but their provider shortages and access to care remains a large barrier for many of these millions of children. Adult benefits under Medicaid have been considered optional to state programs, and Medicare has never included routine dental benefits for the millions of retired and disabled adults that it covers. And that is the important topic we're here to talk about today. So, formidable barriers and deep ones, interesting ones.
Formidable and deep. That's completely true. Dr. Monopoly, I just want to get an idea of some of the efforts that have taken place historically to mend this division, to include oral health. And now we're specifically talking about Medicare, starting from, let's see, 1965. Why wasn't it included then? And since then, up to obviously this moment, what has really happened in terms of all the efforts?
Sure, I would like to start by saying I too am honored to be a part of this panel of such expertise, and to thank everyone for joining us this afternoon. I think the basic component is that multiple efforts have been made to add oral health into Medicare since 1965. I think it's clear that a program that it's as large as Medicare, it's really difficult to make changes that are adding new benefits. And for example, for Part D, Medicare never paid for drugs until took 40 years for that to happen. That it takes a lot of alignment and unity to be able to go to policymakers in Congress to make a change in Medicare. And I think that really hasn't existed well in all the attempts that have been made in the past. So there have been multiple bills proposed. They never seem to have gone anywhere, mostly because there wasn't that alignment between providers and stakeholders and consumers and advocates. And I think a lot of the conversation in most of those efforts have been a bit provider centric about what it would take for providers to be a part of the program, and most of the conversation about what it would mean for the public has been if there's providers that are happy, then the public will do better. So I think that I think what's different now is a different political environment. That part of the issues that we've had around lack of bipartisanship have created the sense that reconciliation is a way to move things forward, and that the Democrats who are in charge of all three branches are willing to use reconciliation to move something forward, and that all the other, we can get into some of the other factors when we go forward, but I think we're at a place now where there has been a more concerted effort among stakeholders to get ready for any political opportunity, a window of opportunity to move Medicare forward.
Definitely, and you talk a lot about stakeholders. I just want to get an idea of who these stakeholders have been that have been really pushing for change since 1965, and because stakeholders are important. Professor McDonough will tell you that, and I mean, we actually wrote a paper about some of the stakeholders involved in national oral health reform. So who are these stakeholders who've been really striving for change?
Well, I think consumer groups have come together and over the last 4 or 5 years have really been aligning around their advocacy. I think Families USA is a national group that has been bringing a lot of the consumer groups together. AARP has been in favor and supportive, along with all the other issues that they are supporting for elder adults, but that AARP is strongly supportive. And Center for Medicare Advocacy, which is a consumer group, has been there, and Justice and Aging, the Oral Health Progress and Equity Network, which has just basically formed over the last 5 years, is a wide group of community voices that have been helping to move things forward, and Community Catalyst. And I think along with that, a number of provider groups have started to be in favor and to help to move things forward. A couple of advocacy groups are my organization, which is the CareQuest Institute for Oral Health, and the Santa Fe group as advocacy organizations around providers. But also, as we'll hear this afternoon, the National Dental Association has been supportive and helping to move this forward. The Hispanic Dental Association, American Association of Public Health Dentistry, the American Public Health Association's Oral Health Section, the American Dental Hygiene Association, Hygienist Association, and the National Dental Hygienist Association have been supportive, and the Gerontologic Society of America as well has been doing a series of webinars in support of moving things forward. And altogether, I think that over the last 5 years or so, there's been a time where consumer groups have been coming together to look at the political environment, and have been publishing articles and engaging their members, and are engaging policymakers around this specific issue. So I think that's what really brings us to where we are now.
Yeah. Thank you, Dr. Monopoly. It really does take a village. And now all this, all these efforts have led us to where we are now. There is, Professor McDonough, there's immense activity and excitement in Congress right now regarding the 3.5 trillion package, just called Build Back Better, to be included in the budget reconciliation. And this includes, obviously, the expansion of Medicare to include dental, vision, and hearing benefits. I just want us to get some background on what is this Build Back Better package, if you could tell us.
Well, so thanks for having me. Pleasure to be here. Congrats to Jane and to you, Shinam, for your great leadership in terms of organizing the oral health community around so much needed improvement. So something really special and important going on here. Thanks to both of you and others. So this is one of those magic moments in American political history when Democrats who generally support expansion of social services and the social safety net control the White House, the House of Representatives, and the Senate. So they have what's sometimes referred to as the trifecta. And in those moments, they're able to advance agendas that could never happen when we have divided government. And they happen not that often. In the past 40 years, there have only been 4 years of Democratic trifecta control. That was in 1993 and 94, the first 2 years of Bill Clinton, and 2009 and 10, the first 2 years of Barack Obama. And now we're in the first 2 years of President Joe Biden. And once again, there is a trifecta. And so this is the moment, as it is for most presidencies, to try to advance through legislation and new laws, your agenda. And so the Build Back Better package, which started at 6 trillion, went down to 3.5 trillion. And now people are arguing about what the size will be. Should it be between 1.5 trillion or perhaps just shy of 3 trillion? And that's part of the legislative process. A lot of people look at what's going on right now and say, isn't this terrible? They're arguing and they're disagreeing. That's the work of lawmaking. That's how it's supposed to happen. And that's what's going on now. It may not come to a happy result, and it may. And of course, there will always be, regardless, some people happy and some people unhappy, regardless of where it ends up. The Democratic majorities in the House and the Senate are razor thin, 50-50 in the Senate, with the vice president providing the deciding vote, and only about a 3 to 4 vote margin in the House of Representatives. So no room to spare, and certainly no room to get something done that doesn't have Republican support unless you use the special budget process known as reconciliation, which has lots of different rules around it and basically allows senators to advance legislation through the Senate that can't be subject to the 60 vote threshold filibuster. And everything in it needs to be directly related to the budget and fiscal matters up or down. And so that's what Democrats are trying to figure out right now without Republican support. And there are about 2 senators in particular who are expressing lots of public reservations about the 3.5 trillion and not being that specific about what they would accept beneath that. And that's Senator Joe Manchin from West Virginia and Senator Kyrsten Sinema from Arizona. So a very difficult moment and still yet a moment of opportunity. Folks have been trying to get dental benefits into Medicare, as Mike mentioned, since the creation of the program in 1965. And it's always been kind of a second tier issue and has then ended up in the process on the cutting room floor, particularly because of the opposition of the American Dental Association, which is one of the most active groups in the healthcare community in terms of a political action committee that makes donations to senators and representatives and all kinds of political campaigns. So difficulties. And at the same time, and this is the last thing I'll say, and I'll pass it on. But so there is within this Build Back Better, 3.5 trillion, 2 trillion, 1.5 trillion, whatever, going to be some package that relates to expansion of the healthcare system and particularly health coverage. There is the dental benefits piece. There's also the filling in of some important gaps and inadequacies in the Affordable Care Act, the ACA Obamacare structure that needs to be added in that's also expensive. There's also an agenda to try to regulate prescription drug prices in the United States. And if they succeeded in doing that, then just that measure alone of prescription drug cost control would provide the money potentially to pay for all of the other things that Democrats want to achieve in the healthcare space. Right now, as we speak, the messages coming out of DC say that the package is shrinking. So some things that people have been counting on, including like climate change, education, childcare, you name it, are going to end up on the cutting room floor. And there's also pressure on the prescription drug price control as well. And so unclear how much of that might happen. So we're in a moment right now where the window of opportunity for something to happen is starting to shrink. And there is competition and uncertainty, including about dental benefits for what we'll get through.
That's exactly what I really wanted to get to. Is it almost seems like a do or die moment for the Biden agenda, if you will. How would you? I mean, I want to talk about the elections in 2022. How would you relate this to that? Is that why we're feeling this kind of immense pressure to get something done because it feels like a do or die moment?
There is immense pressure on the Democrats to deliver on their big promises made in the 2020 presidential and congressional elections. There is a pattern that has been broken only very rarely over the past 60 years, that in an off-cycle election, after the election of a new president, the reigning party, whether it's Republicans or Democrats, will lose control of either the House or the Senate or both. That's what happened to Barack Obama in 2010. Donald Trump lost the House in 2018, didn't lose the Senate, lost that in 2020. So there's a moment of risk, but there's also this belief among Democrats, well, if we can just get this done, then we'll have something to sell to the public and they'll be happy and they'll reelect our majorities to Congress. But it's also worth noting that in 2010, in March, Barack Obama signed the Affordable Care Act into law, and that did not prevent the loss of the House and the Senate. in the 2010 midterms in November 2010, where they lost the House and the Senate, and Barack Obama had divided government for the last 6 of his 8 years.
So just to get an idea of, there are so many things in this Build Back Better, like you talked about, there's immigration policy, there's climate change within just the healthcare agenda, there's drug pricing, there's closing the Medicaid care gap. Where does oral health stand in that? And if something were to be on the chopping block to get this done, I mean, I'm doing a little crystal ball gazing. What are the chances of oral health being on that chopping block?
Well, what I'd say is that there are 2 words that are the big advantage for dental, vision, and hearing benefits in Medicare. And those 2 words are Bernie Sanders, the senator from Vermont, the chair of the Senate Budget Committee, who has been an advocate for oral health. He's been filing bills on oral health going back, I believe, to the 1980s, and very much as a member of the Senate. So he can hardly be called a Johnny come lately or a Bernie come lately to this issue. He's been in this space for a while, and this is the moment that he wants to deliver. He wanted much bigger things. He wanted a public option. He wanted to lower the Medicare age of eligibility. All of those things that people talked about in the election are already on the cutting room floor. And dental benefits and hearing and vision is now the big thing that Bernie, who is one of the key movers in the Senate, he's probably up there with Chuck Schumer in terms of his importance, is determined and thoroughly committed to get. And so that is one of the reasons why I would caution anyone to casually say, oh, dental benefits is going to end up on the cutting room floor, because there is some intense and a highly effective and influential advocacy at the highest levels of the Senate to keep this in, whatever may happen. And nobody's really against it. It's really just one of those situations where you really have to measure the value of competing health priorities that everybody would agree, or not everybody, but many, many people would agree are highly valuable and desirable, and you can't do everything.
Thank you, Professor McDonough. Just going back to Dr. Monopoly and Dr. Alston, how much do we really know about the nitty-gritty of what is being proposed in this, for this dental benefit and this expansion of Medicare to include this dental benefit? Do we know the details of what that might look like?
Well,
I
there
would say-
are organizations.
I'm sorry, please go ahead.
Oh, okay. First of all, I'd like to thank you, because I'm part of this very important conversation. Yes, oral health professionals are very concerned about what this benefit will look like and how they can advocate for it. We are receiving information from our dental organizations and keeping up to date as things change so quickly. And we're anxiously awaiting to see what the Senate version is going to look like as well.
Yeah, I would say this is a very complicated discussion. And so right now, most of the discussion has been around the House's version of the bill. The Senate hasn't weighed in yet. And once the Senate weighs in, then those 2 versions would need to be reconciled. And once that happens, then the Congressional Budget Office would do a score and actually say what the benefit will cost. Right now, there's lots of conjecture around this is what it will cost. And I've heard lots of information about that there's not enough in the budget to do it, but the cost isn't really defined yet, that we need to get that, and then we could start a discussion on the things that still have to be determined. What does the benefit look like? What will the payment methodology be? That still needs to be determined. I guarantee that it will be different than Medicaid, because the states define reimbursement for Medicaid. And that it will be something that will have to be decided. The implementation time and the administrative support for it still need to be determined. I think there's been a lot of discussion around that it will take years and years to implement, but CMS is it's what CMS does. So I'm thinking that it will take much less time than has been talked about in the media for it to happen. And then frankly, this administration has a strong incentive to get it done quickly for all the reasons that Dr. McDonough talked about. And then, where in Medicare would it reside? A lot of the consumer groups have been advocating that it be a part of Part B, because that's where outpatient care is. That's where they feel that it's most equitable. And within Part B, the premiums for Medicare would be, and for Part B would be means tested. So it would be, again, an equitable way for things to move forward. And if it's in Part B, then all the Medicare Advantage plans would offer this, have to offer the same more extensive benefit. So I think that that's where we are now. And I'll just say, everyone's agreed on that the oral health community really needs to be at the table and really needs to be a part of the implementation if this actually moves forward. The concerns of providers must be addressed, and the concerns of payers must be addressed. And consumers must have a strong voice at that table to make this happen in a way that is going to create a strong oral health benefit that we all are interested in.
So just to give voice to the larger dental community, what are some of the positions, without actually naming the organizations, from say payers or some discipline specific associations or even dental trade organizations? I mean, what are their positions around what is being currently at least lately proposed? Even the medical community, if you could actually shine a light on that.
Well, for one thing, there's not a consensus around whether all Medicare beneficiaries should be able to have this benefit. There are some organizations that feel that there should be means testing and that you have to be 300% or under the federal poverty level. Other organizations like the NDA and Families USA and their coalition of organizations believe that it should be available to all Medicare beneficiaries because regardless of income, they share risk factors as far as chronic diseases, and those are the same risk factors that also pertain to oral health. So that is one thing that they're not in alignment over. The other, Dr. Monopoly spoke about it, is where this benefit would be placed, because the benefit will look differently if it's in Part B or if it's like a separate part, like a Part T.
Yeah, and like you said, and I just want to reiterate that again, there are organizations that have come out in support for the inclusion in Part B and comprehensive benefits. I mean, NDA and ADHA and I think we've heard of American Heart Association also. That's one of the organizations that is supporting this. So I just want to quote a stat that I found in a document that's the Wisdom Tooth Project in 2018. Health Policy Institute had actually conducted a survey to understand the views and attitudes of dental provider community on adding dental services to the Medicare program. So around 71.2% of dentists at that time agreed that Medicare should include comprehensive dental benefits. And a majority of dentists indicated that they're willing to comply with typical Medicare practice requirements, such as reporting diagnostic codes, using electronic health records, what have you. But like the situation on the ground is quite complex. We are hearing concerns about these very things, even though there is data, albeit old data, that there was support on the ground for these issues. Can you, I mean, either of you, Dr. Alston, Dr. Monopoly, speak to what are some of those concerns, some of the top concerns, and what are they legitimate according to you? How would you address them? Either of you can take that.
Well, as Dr. Monopoly stated earlier, one of the concerns is reimbursement because, I think some people think about Medicaid and how the reimbursement levels are low. And even dentists who want to treat the patient population are concerned about whether they can, they can provide it and meet the costs associated with it. So cost is one thing, reimbursement levels. Another is, I believe the copay and the cost sharing, that that patients will have to pay, will it be unaffordable? Because, you know, when you think about like the possibility of 50%, you know, for major services, that may still be affordable to people who, unaffordable rather, to people who are, you know, who have the benefit. So that's another concern. Also, because, you know, if it's not viable for providers, then they, even if they want to serve the patient population, you know, they won't be able to do it. So will there be a sufficient provider network? Also, the scope of services, because you want to be able to complete treatment plans, you want to be able to give patients a dental home, and you want to be able to maintain their oral health. So if the scope of service is so narrow that you can't do it, it will be difficult, you know, for to do what you ethically want to be able to do.
I would say to your point, I guess it's old data, but it's 2018 data, so it's not that old, the survey, and that I agree with everything that Dr. Alston said, that you know, the issues that are there are concerns, but again, they're concerns that I think will be more valid to talk about once we have a good sense of exactly what the proposed benefit will be. I think you know, if it's in Part B, the standard copay in Part B is 20%, and then 80% is paid by Medicare. I think all of the advocates that have been that have a deep understanding of Medicare have been saying that that in Part B there's the capacity to be innovative and to have different levels of copayment, but that certainly is, we want to make sure that whatever benefit exists, that it's usable and affordable by the Medicare community. But I think the bottom line is that the Medicare is a social contract because people put into it through their whole lives, and once they're at retirement age, then they're eligible for Medicare benefits, and everyone's eligible for Medicare benefits, and that really is where the political power of Medicare to be stable is, that it's a, you know, if you hear about Medicaid programs, there's in April we're going to end adult dental and Medicaid, but if it's around Medicare, it's, and everybody that was born before 1975, when they are Medicare eligible, this will happen to them. And if we're going to make this change, it's for people that were born after such and such, so that there's always an opportunity to have a long-term vision. And I've often heard of tinkering with Medicare as a third rail, so that it has much more political support because of its sense of entitlement. But for sure, as I think everyone's agreed that that oral health professionals need to be at the table, and that it needs to be implemented in a way that is accessible and works well. And you know, right now there's a new chief dental officer at Medicare who is in the administrator's office. So I think that bodes well for that voice to be there.
I think it's also worth noting that there are some non-dental community stakeholders that are weighing in on this in ways that people might not see coming, that might be a bit of a curveball. The example that comes to mind is the part of Medicare called Medicare Advantage, where instead of just going to physicians or hospitals, you get your care managed through a private insurance company. And they provide dental benefits through Medicare Advantage, though it's partial, and it doesn't cover the expensive stuff that really hurts people's pocketbooks. But they are expressing reservations about expanding Medicare, creating a Medicare dental benefit that might then compete with people who choose to pick a Medicare Advantage plan because it includes dental benefits. So there's lots of examples of that kind of level of involvement in this issue that complicate it and create some more uncertainty around what may happen at the end of the day.
Definitely. I want to move the focus from it being a little provider centric, as we started with, and a little more patient centric at this point. Mary, Otto, Dr. Alston, these questions are for you. I'm going to again look at some data. National surveys conducted by Families USA show that 8 in 10 voters favor adding dental coverage to Medicare. The support is even higher in 2022 Senate battleground states. So going back to what will happen next year. So what does inclusion of dental benefits mean for health equity? We know that even with insurance coverage, there are often still barriers to receiving quality dental services, especially for marginalized populations. So what does expansion of Medicare really mean for these vulnerable populations? Mary, Dr. Alston, anyone wants to take that?
Well, we know that a number of older Americans, Medicare beneficiaries, suffer with chronic diseases. They're on medications that have oral effects, and they need, in order to have improved overall health, they need oral health care, and they're not receiving it now. So we know that if they were able to receive it, they would have overall better overall health. And I do believe that a dental benefit in Medicare would promote the integration, a better integration of primary care and oral health, and also a better integration of behavioral health and oral health, and also access to some services that they're not currently receiving. Like I would think patient navigation, health coordination, those kinds of services would also be available to them. And what's important is being able to have a dental home, because right now, where do they go? The emergency department, when it gets so bad, that's very expensive. But with a dental benefit in Medicare, they could have a dental home as well.
Mary, do you want to add to that?
Those are wonderful points. It's seen by a lot of the groups that Dr. Monopoly mentioned earlier as an important way of bridging or addressing this historical divide between oral health and overall health. The divide that Dr. Satcher spoke so eloquently about in his 2000 Oral Health in America report, where he called upon the integration of dental care into our healthcare system in a way that creates a system that serves, the oral health of all Americans. And under the social contract of Medicare, that would be seen as an important step, including dental care as part of the healthcare benefits that beneficiaries are entitled to, under Medicare.
Thanks, Mary. Mary, I know you're currently working in Appalachia. I know you're currently writing something around there. Are there any patient stories, something on the ground that you've heard that share with us on this platform today?
I got interested in the deep healthcare needs of Central Appalachia as a reporter, and I've been spending a lot of time there, looking at not only dental care, but mental health care and primary care needs, especially amid this pandemic, which has really been shed such a bright light on the health burdens and disparities there. And as difficult and challenging as these times are, though, there's also been some interesting developments that are important to our national perspective too, I think. And one example of that is, individuals living with burdens, but also the interesting way that federally qualified health centers and other community health centers have been adding dental and mental health benefits to the menu of primary care services that they provide to these high needs populations in communities, including those in Appalachia, places where geographical barriers and economic barriers and healthcare burdens all contribute to disparities. And the Affordable Care Act has encouraged whole patient care and incentivized whole patient care in ways that are making a difference in some of these communities. Although, the pandemic has made providing care more challenging in recent months, this infrastructure is there in a way that's interesting. Medical and dental health, mental health records are getting integrated. Patients are finding warm handoffs, so they don't have to bridge that lonely divide by themselves. Between these different services. Interesting, very interesting stories unfolding there.
May I weigh in also?
Of course, Dr. Alston.
So I have a story to share with you. I've treated a number of children who were brought to the office, the clinic, by grandparents. The grandparents do not typically have legal custody of their grandchildren. They're simply helping their children. Some actually help their children at great financial sacrifice. They go without needed services such as dental care that they could afford if they weren't financially helping out their children and grandchildren. And it is the seniors with poor dentition who value their grandchildren's oral health so much that saddens me because it's, what they're doing is they're sacrificing their own oral health so that their grandchildren and children have a chance. And, it's more than a truism that it's not how much you make, but how much you keep that makes the difference. And I see seniors who get more than, and sometimes much more than 300% above the federal poverty level, but they keep very little. And I believe that if they had a dental benefit in Medicare Part B, even with the premium and copayment, they would be more likely to access dental care.
Thank you, Dr. Alston. I am looking at some of the questions, and we have a few questions from the people who have joined us here. Dr. Fleming asked, for the panelists, how do we engage dental providers who are resistant to dental benefits in Medicare?
Well, I think it starts with information, because there's a lot of misinformation out there, a lot of fear out there. When they think Medicare, they think Medicaid. And, they are going to be Medicare beneficiaries sometime in the future. And, I don't know of a single dentist that did not go into dentistry due to compassion for others. So we need to really draw on that compassion and remind them of the social contract that dentistry has with the public.
I couldn't agree more, and I think it is information, but information that is targeted towards specifics and what really is on the table in terms of the policy going forward, and hopefully engaging professional organizations and other organizations that dental providers are a part of to make sure that they get the right information and can make an informed decision, and definitely be there to lend a voice that would create a program that is that works for providers as well as for patients in the community.
I think it's worth keeping in mind that in 1965, physicians were overwhelmingly against the establishment of Medicare. And they quickly learned that it had significant, substantial advantages for them in a variety of different ways that they continue to take advantage of. So I think that over time, and not that quickly, if this actually happens and becomes implemented with the involvement of the dental community, which would be absolutely a certainty, that it will be a similar pattern.
And also in the events of 1965 led to some very powerful and interesting reorganizations of the workforce around healthcare, with the, growth of mid-level, physician's assistants, nurse practitioners, and similar work has been going on in the oral health field as well. So, and some dentists have embraced these workforce models as ways of expanding access to care in their communities. It's still a kind of a hot button topic, but also a very powerful and interesting one.
I also wonder if it's these changes that we're talking about is actually causing some of the reservations in the dental community who are resistant to perhaps change. But one of the questions that I have here is actually quite interesting, and it speaks to that kind of changes. Is Medicare the first step in promoting value-based care in dentistry? Is that something that we will see if Medicare is to become, oral health in Medicare is to become a reality? Dr. Monopoly, do you want to take that?
So I have to, one of those get caught. I was actually reading the chat because the chat is so amazing with the group that we have, and I missed your question, so I apologize. I was afraid you would call on me first.
I'm sorry. No, I was just talking about just in the larger dental community, and the change that has followed on the medical side after Medicare, and is one of those changes, as someone has asked, related to value-based care, and does Medicare kind of mean that that is the next step in which dentistry might go?
I think certainly it is something that would be on the table for discussion. But I think that part of the reason why I was attracted to the chat is that there's a lot of conversation about improved health outcomes and the way that oral health providers can be there as a way to improve health and well-being. And I think that is the trend going forward, and I think it will actually help providers to be reimbursed for their outcomes rather than for the number of procedures that they do.
Yeah, definitely. I mean, we have a lot of interest around some of the stakeholders that are involved in this, and Professor Donoff asks, what is the position of the AMA on this issue? The growth in the population 65 and older makes this the right thing to do. So do we know what the medical community's position is?
Standing back. I haven't seen anything that is an absolute position. But
I haven't heard anything either that is an overt presence from them in this. I think they defer to the ADA, certainly, as they would want in reverse. I think there's something else that's worth mentioning, though, which other folks, everybody else more than me, but I'll put it on the table, is the changing nature of dental care in the oral health industry in the United States. The days of the solo practice and the small practitioner and the more pure solo business person, dental office practitioner and owner is rapidly shrinking, as opposed to people coming out of dental school and going to larger practice groups. And so I think that there's a generational shift going on. And I think that you can also observe different attitudes, different context, different reactions to this notion that are different generationally. The next generations of the dental health industry are going to be totally engaged and active and committed as the prior ones, and it's going to be different. And I think that there's going to be more of an acceptance of this kind of advance by those rising generations of oral health practitioners, dentists, and all of the other affiliated practitioners.
And I would just add that the growth of federally qualified health centers has also played a role in it, because You know, we're already integrating primary care into oral health in a bidirectional way. The same for behavioral health. We use electronic health records, and we embrace new models like value-based care. You know, we're ready for it. So I think that will also play a significant role as well.
So lots of changes to be expected for the better, hopefully. I have this very interesting question here. It's a little bit of a, puts it in a negative light, but what fact, so are we moving towards a world where dentists will refuse to accept any insurance, but Medicaid or Medicare or so on and so forth? Does anyone want to answer that?
I would just say that that is a trend, that it is observable and measurable. And it's also true of many parts of the medical care industry. Psychiatrists, psychologists, social workers, increasingly not taking any insurance at all. I think it's far less true for the MDs, particularly the specialists, because their bills are so much higher and they lose too much of their market. So you won't see them abandon it. But other practitioner categories, that's absolutely a trend. But there's a decision point where going and not taking insurance crosses over with the ability of people to be able to pay your bills and get your business. So I think it can only go so far, but it can absolutely, and it is happening.
I think we have time for one question before I get final thoughts from everyone. Dr. Seymour from HSDM asks, what do the panelists see as the role of dental education in cultivating a strong culture of compassion for others, ready to enter into a social contract with skills and abilities to practice in this way? Who wants to answer that?
That's a huge question, and and I think it goes all the way from pipeline and you know, what types of individuals are interested in pursuing the dental profession, and then you know, what are the challenges and the ways that selection committees can work towards what kind of people are trained as dentists, and then through the education process to you know, have a small business mindset, but also to have a larger mindset of the role that we play as professionals, and if we're self-monitoring professionals, that we need to address and be sensitive to the disparities and the really negative outcomes that happen because of the way that our profession is currently structured. So that is a hard question, but that is a key question going forward.
Yeah. Thank you so much, everyone. This has been such a rich discussion. I just want some final thoughts. I know we're running short of time, as I knew we would, but final thoughts around where we see this going forward. I feel we're living through history right now. Final thoughts from everyone. Starting with, I see Professor McDonough on my screen. So starting with Professor McDonough.
Okay, so this is one of those moments when there's opportunity, there's risk, there's danger, there's other kinds of things. And it is the moment for everybody who cares about this and has an interest in this to step forward and raise your voice, whether it's talking with elected officials, whether it's writing letters to the editor or op-eds or something like that. This is the moment when it really matters and when it really counts, and it's really at stake, and it could get lost and it could stay in. And a lot of that is how much the American public are able to raise their voice in a way that breaks through the veil of indifference.
I'll just simply say that I hope that dentistry will be on the right side of history.
Well said, Dr. Alston, well said. Mary, last thoughts?
To add to just those two excellent thoughts, there are two more words to add to Dr. McDonough's two words, seniors vote, and they're very powerful force, you know, in the election process, and they're a growing part of our American population. So if they make the connection, you know, to this issue as part of this large, vast social spending plan, and let their lawmakers know, you know, if that would be an important point, I think.
And
I couldn't agree more with everything that's been said, and I think this is the closest we've ever come to actually having oral health be a part of Medicare, and I think it is an inflection point, and it will be interesting to see where we can go from here. I'm so optimistic just because of reading the chat and the people that are part of this webinar. I think the comments that have been made are amazing, and always in an hour and such a complex issue, there's so many things left out, and I think a lot of the important things were posted in the chat. But this is our time. I'll just put it that way.
it is indeed. I really want to thank everyone for being here, for discussing this really, really complex issue. We wanted to cover so much more, but there's only so much time. I also want to thank the Office of Global and Community Health, Jane Barrow, Christina Cassano, and a very special thanks to Dr. Elizabeth Alpert for organizing this event. Thank you so much to everyone who joined us today. Hope you have a wonderful weekend. Goodbye.